Welcome back. For this session, the focus is on innovating ventricular ablation, dual modality ablation. I am joined by Ammar, who will present a case from Mayo Clinic. We're also joined by Pasquale Santangeli from Cleveland and Tom DeParter from Aalst, Belgium. Welcome all. Ammar, over to you.
Devi, very nice to be here with you all. So I have a very interesting case to present that caused us some trouble, and I'd like to illustrate that for you. This is my disclosure slide. Waiting for it to pass through. So I'll just begin with a brief background. So we know when we're delivering radiofrequency ablation, especially with the epicardial aspect arrhythmias, there are certain challenges that we have to contend with. One is the issue of epicardial fat. Of course, proximity to the coronary arteries may be problematic because of concern of injuring them. And then in about 5 to 10% of cases, depending, of course, where the abnormality of the arrhythmia is, we may be in proximity to the phrenic nerve. And so concern regarding injuring that with radiofrequency. When we're one other potential limitation is if there is scar, can we penetrate that with conventional thermal ablation? And so this was a study by Dr. Santangeli's group, basically showing that when you're trying to deliver radiofrequency energy over a scar region, you don't get the same temperature rise. And it's been shown that the lesion parameters may not be quite the same as what you would otherwise expect in non-scarred myocardium. And therefore, because of that, we really would like to have better ablation tools. And so the same group, as well as others, have looked at radiofrequency versus pulse field ablation in certain areas and demonstrated that you may be able to get deeper lesions with pulse field ablation relative to radiofrequency, as shown, for example, in this animal study where PFA demonstrated deeper lesions and larger lesions overall in areas such as the LV summit and the epicardium. So I'm going to just move on here. Sorry, there's a bit of a lag on my mouse. So we know that PFA may penetrate fat better as well, and therefore it may be used to leverage certain cases where RF may not be as desirable. So I'm going to present the case of a 53-year-old female with very symptomatic PVCs. The burden was 35%. She had also undergone 2 prior ablations with a very experienced operator, and unfortunately, despite that, continued to have PVCs. Her EF was 25% with NYHA class 2 to 3 symptoms. She'd failed metoprolol and diltiazem, and was very keen to avoid antiarrhythmic therapy. Class 1 drugs were obviously not desired because of the low EF, and given the young age, she did not want to be on amiodarone. So with the prior ablation attempts, the first procedure, the earliest activation was in the RVOT, and ablation with radiofrequency resulted in suppression. Additional mapping in the CS and LVOT was subsequently performed due to some PVC recurrence, and it was actually found that the earlier site was in the proximal AIV, close to the LAD, and therefore no ablation was performed. Some ablation on the endocardial LVOT below the left cusp was performed with no effect. She returned for her second procedure due to ongoing PVCs, and an epicardial approach was undertaken, but unfortunately was somewhat limited because there was a mechanical bump when they were mapping in that proximity. And so some ablation nearest the earlier site was performed, and ultimately some RVOT ablation was also performed at the site where they had previous suppression. She did well for a few days, but unfortunately had PVC recurrence again. And therefore, after referral to us, we had discussed management options, and it was elected to proceed with a 3rd-time ablation attempt, and we were able to obtain compassionate use approval for use of a dual modality radiofrequency and pulse field ablation catheter. So these are the PVCs. You can see the morphology is consistent with an LVOT exit. And you can see a very delayed maximum deflection index, possibly suggestive of an intramural or epicardial focus. You'll have to excuse the delay, I'm sorry. So we'll move on to the video now. So this is a composite video showing the approach for this challenging case. So we use the EnSight mapping system and the HD GridX catheter. We really wanted to perform very meticulous mapping, given that this was a third-time procedure and had really been very challenging in the previous 2 attempts. And so the general approach is to start with sedation, but unfortunately, because of disinhibition, we had to move to general anesthesia. But thankfully, the PVCs remained very frequent throughout the procedure. I like to have a catheter with an indifferent electrode so that I can have a unipolar signal for recording as well as for pacing. And then I typically will have a coronary sinus catheter within the CS for atrial and ventricular signal recording, as well, of course, for the Summit PVC to get activation timing. Now, one of the challenges was that the A and the V were often fusing, and so we had to be really careful when we were annotating in the CS AIV region. So as you can see, we started out with the RVOT first, and it's hard to appreciate from the quick video, but basically, even though we were taking a lot of points, we were meticulously annotating each one, or at least reviewing each one to ensure that we were happy with the way it was annotated. And so you can see the white dot showed the earliest site of activation from the RVOT. Now, in the first case, the operator had decided to perform ablation from this region and see the effect. But generally speaking, I like to look at multiple aspects before we commit to an ablation, unless we have a very attractive signal, especially given that this was a redo procedure. And so we used a decupolar catheter in the coronary sinus to perform, again, detailed mapping. And as you can see from the fluoroscopic images and the corners, we use that to advance a sheath into the coronary sinus. And then we performed a dedicated venogram in the RIO and steep LAO caudal views to really try and highlight the anatomy in case we needed to perform some venous mapping. And so this was performed, and we interrogated various veins. Nothing was really particularly attractive beyond that of what we saw in the AIV itself. And so you can see here through with the video that we continue to annotate signals and obtain further mapping, again, really being very careful. You can see in the top left the ICE image of the LV. Even though it's a time lapse, you can see that the LV is significantly diminished. So we switched out the AIV for a mapper to, again, try and use the various veins, and nothing as attractive was found. So we thought we had a target from the AIV, but we looked in the endocardial LV as well, just to really make sure that we've essentially looked from all vantage points. And you can see here, based on the activation map, and I'll show you this in more detail in a moment, that the LVOT was significantly later, but I'll highlight why it was important to show you this for the purposes of this case. And so at this point, we've mapped RVOT, we've mapped GCV as well as LVOT. And so this is the activation map. And if you look in the top right corner, you can see the activation clearly starts in the AIV, followed by the RVOT, where that white dot is, and then later on the green dot in the LVOT. And what we're looking at here is the triangulation point essentially between those regions. And what we can see is that there is a significant distance between them. Now, again, it's not a perfect way of doing it because of the potential inaccuracies, but on ICE, we could also see that the tissue was really thick, as you can see from the images coming in and out. And so this is the activation for each point. This is the earliest site that we found in the AIV. And you can see that there is a small R wave on the unipolar electrogram in the bottom right. This is the earliest site from the RVOT. Again, this was not as early as what we had seen from the AIV region. And then in a moment, we'll move on to the LVOT, and you'll see how we were essentially on time. So really not an attractive activation point in that sense. So then we went back with the ablation catheter into the anterior interventricular vein. We had a bit of difficulty getting back to the exact position, just I think partly because of the maneuverability difference between the CS catheter that we had and the ablation catheter. But then after getting into the relevant area, we went to perform a coronary angiogram just because of the concern that we were in close proximity to the left coronary arterial system. And so you can see here in the angiograms that we're essentially sitting right over the left anterior descending coronary artery. And we're very close to the site of earliest activation that we wanted to ablate from. And so this will just play for a moment just to see. And you can see that the PVCs remain very frequent. And so we were discussing the approach. Given that this was a third-time redo, we thought it would be reasonable to proceed with ablation here using PFA. And you can see on the recording system the noise in the middle of the screen. And that's the change from when we switched from an RF modality to a PF modality using this system, which is not yet commercially available. So this will not be on the commercial system. And ultimately, we decided to proceed with ablation, and we pre-treated with intracoronary nitroglycerin, and we were ready for any potential issues. And you can see here that we're about to deliver the first PFA lesion. And there's the pulse, and it's a train of 5 pulses that are R-wave gated. And this was using the TactiFlex Duo ablation catheter. And so I just want to reiterate that this is not an approved indication, and hence why we obtained the compassionate use. Now, with the first delivery, we did get some suppression, but then shortly after, we would see the PVCs again. And so you can see here that we performed repeat deliveries. And this is the coronary angiogram composite video, just showing you just how close we really are to the left anterior descending artery. And we had a lot of discussion about whether or not to even perform ablation here, but we were ready in case of any potential issue with the guide wire engaged in the coronary artery. My colleague from interventional cardiology was scrubbed in next to me, and we had all equipment ready in case we needed to do anything. But thankfully, you can see there was actually no spasm whatsoever. So we did a total of 8 deliveries here. And again, we could suppress, but the PVCs would promptly return. And so it was clear that with ablation from this region, we were not having a substantial effect on the PVC. Now, whether or not some of this may be automaticity that's returning because of the PFA, it was difficult to elucidate, though we thought it was just inability to actually target the main focus. And so after we had performed ablation within the AIV, we then decided to go back to the pulmonary artery and RVOT because that's where we had found the earliest activation sites. And so we did a combination of ablation lesions here using both radio frequency, as you'll see in a moment, as well as pulse field ablation. The reason for that was based on some preliminary data with a different catheter, dual catheter system, which suggested that you may be able to augment the lesion size by preconditioning with radio frequency. And so here you can see that we're performing radio frequency ablation. And again, we suppress the PVCs if you look at the bottom, but then they quickly return again. And a significant amount of ablation was performed here. But one of the issues we were having is contact. And you can see that in the top left image on ice. We were essentially above the pulmonary valve and it kept pushing us away. And so despite our best efforts, we didn't think that we were getting a good enough lesion, good enough stability here, even though we performed both radio frequency and pulse field ablation. Now, I just want to highlight the different colors that you're seeing are based on the lesions performed. So red is radio frequency, and that is color-coded based on impedance. And then the orange and blue are based on the contact force for PFA. So because of the difficult contact, what we decided to do is perform a loop within the pulmonary artery and then come back down over the pulmonary valve and sit right on the cusp, as you can see in the top left image on ice. And what's interesting to note is that we're actually lower on our map than we were when we were coming antegrade, so to speak. And so again, highlighting the importance of the contact and eyes for visualization, because even though we're still in the pulmonary artery, we're lower down than when we were approaching it from the RVOT. And so again, with this, we were getting transient suppression, but the PVC just kept coming back. And so we knew it would be a challenging case, but at this point, it was proving to be a lot harder than I think we thought, even with having a dual modality catheter. And one thing we noticed is that with the transient suppression and the PVC would come back, is we would have edema form in those regions shortly after. And you can see on the ICE image again, just how white that region is. So then we went back to the LVOT and thought, well, okay, how about if we ablate from another area as a vantage point? And so you can see the ablation catheter is right on that white dot, which is the earliest activation we saw from this region. The issue is, though, it wasn't early at all. And I showed you that, where it was essentially on time with an R wave on the unipolar electrogram. But we've done this for other cases, for other Summit PVCs. And so we switched here from PFA to RF. And you'll see the noise again from the change. And with that, you lose the ablation catheter on the mapping system. Again, this is just because it's essentially a research system, but for the commercial launch, this will not be the same way. You'll be able to toggle between the two seamlessly. And so we perform radiofrequency ablation here. And you'll see that in a moment. And typical settings varied, but I would say on average, it was up to 40 watts, 35 to 40 watts. And I like to target current as well. And so we were aiming for at least a current of 600, but ultimately about 700. And so again, with RF here, we could suppress the PVC, as you see on the Pruka at the bottom panel, and the suppression was for longer. And so, okay, at this point, we were encouraged that maybe we were able to eliminate the PVC. And so, again, you can see the RF lesions, but this was followed by pulse field ablation, again, on the premise of maybe we can get deeper lesions if we pre-treat with radiofrequency and then PFA. And so we performed several pulse field ablation lesions in this area. And you can see in the top left panel, the ICE image again, right under the left cusp, excellent stability. And you can see that on the map as well with good contact force. And so we performed that ablation there. Again, several lesions. It comes in packets of 4, and we did multiple ones, as you can see from the blue dots, again, indicating contact force was at least 5 grams. And then as we're waiting, we just do additional insurance lesions, but unfortunately, the PVCs will recur, as you'll see in a moment. And so at this point, we're really debating, well, what else can we do? Because we've already performed ablation from every vantage point except the left sinus of Valsalva, and the PVC keeps coming back. And so it was really, to us, a question of penetration. But ultimately, we thought we were making some progress because each time the PVC recurrence would take longer and longer. And so you can see here, we waited for about 15 minutes and the PVCs ultimately recurred. And so we went back into the endocardial LVOT, where we had the longest suppression point and delivered further ablation. And then at this point, we had durable suppression and it did not recur for an hour, at which point the procedure was concluded. So there was no acute complication. As I mentioned, there was no coronary vasospasm. And so I'd like, if you can please go back to my slides now. Thank you. So just to summarize what we essentially performed, this is a 3D electroanatomical map of the mapping and the ablation site. So the earliest activation site was within the AID. Again, note that though it was early, there was an RS electrogram on the unipolar signal. With PFA, we could only suppress it, but it would quickly return. And so we performed ablation from the RVOT above and below the pulmonary valve, as well as from the LVOT and left sinus of Valsalva. And with that, we're able to achieve durable suppression. This was the signal at the site of elimination of the PBC from the LVOT, and you can see it's essentially right on time. Not anything that you would think is particularly attractive, but again, we had ablated from multiple vantage points. And we did obtain an MRI on this patient, as you'll see in a moment, just to assess the lesion formation. Can you go to the next slide, please? My clicker's not advancing. There you go. Thank you. And so you can see that there is a new lesion on two-chamber delayed enhancement imaging corresponding to the site of ablation that we performed. And at 3 months follow-up, the patient had significant symptom improvement and PVC burden was less than 1%. So I'd like to stop there, and then I'll be happy to take any questions. Thank you for your patience.
Wow, Ammar, that's all I can say. All right. I have a question, and I don't do a lot of ventricular ablation anymore. And after seeing that, I'm going to stay in my lane. But having said that, I do want to ask you a question about spasm, coronary spasm, and proximity, and using PF in that location. You know, endocardially, we worry about it when we are in the analyst and we pre-treat. I saw that you were ready with your interventional physician, but number one, are you worried about acute? You know, what are you pre-treating? What are you, how are you deciding how far you are? To me, that was close. And number two, are you worried about long-term effects? We saw some data from Tam and his group on PF with coronary artery injury. So can you elaborate a little bit on that?
Yeah, absolutely. And then a very important question. I'm glad you raised it, Devi. Thank you. So we had a very careful discussion with the patient about all of the potential risks that you highlighted, and made sure that she really understood some of the unknowns and the potential risks. And after careful discussion, she still wanted to proceed. And so we were very ready in case something happened acutely. And so we had the guide wire in place, the guide catheter in place. We had all of the equipment ready. We pre-treated with intracoronary nitroglycerin, so as opposed to systemic, just to really make sure that we had the effect in the vessel that we wanted it. And it's hard to illustrate in the video, but we were continually injecting contrast and looking at the vessel while we were delivering, and we were repeatedly administering intracoronary nitroglycerin just to minimize and prevent any spasm. And so thankfully, we did not have any of that. In terms of long-term effect, absolutely, there's an unknown element there, some concern, and we had, again, emphasized that to the patient. And we've discussed even bringing her back, for example, for a CT, at the very least, if not more formal assessment of the coronary arteries, given the concern that even though you may not see anything angiographically, you may have something actually evolving there. And so I think that's a space we need to learn more about.
And Pasquale, can I ask you a little bit about this catheter and the depth? Because that's one of the things that we worry about in ventricular ablation and pulse field application. Do you have any insight on what kind of lesions we could potentially get with this catheter?
I think it's still a great question, first of all. And Ammar, congrats. You chose probably the most challenging case you could find, really, to show the benefit of this catheter. The big question is still open to what extent we can create a deep lesion with this type of platform. I think there is a lot of work in progress, but it seems like that right now with repetition, it can go anywhere between a 6 and 8 millimeter consistently, sometimes deeper in some areas, but again, it's not confirmed. And the question I would have for Ammar is how many repetitions did you apply of PFA per spot? And the second question is that ultimately you got suppression with RF. So the question is, to what extent you think adding PFA in this specific case helped you to achieve durable suppression?
Yeah, excellent question, Pasquale. So we did a lot of PFA. I mean, it was a lot more than we had anticipated that we would need to do, honestly. I think in total, it was about 60 deliveries, 60 deliveries of PFA between the various regions, including the AIV, RVOT, and the LVOT. And so that was a lot more, even though the ablation delivery time is still a lot shorter than what you would do with RF. Ultimately, the suppression was with radio frequency, as you mentioned. And so it's very difficult to know, but prior ablation in the LVOT had been performed by the operator and was unsuccessful. And I think where this catheter was beneficial is that it allowed us the flexibility to ablate in various regions, including near the coronary artery. I would not have felt comfortable performing radio frequency over that site because I think that would have had a very high risk of acute injury. But with the PF, we thought we'd be more likely to deal with spasm rather than acute occlusion. And so that's where I think the benefit may have been. But again, this is a catheter designed for atrial ablation right now. And so I think the waveforms need to be modified for ventricular for these really challenging to treat rhythms.
Can I ask any one of you how you would, just for our audience, are there certain PVCs that you would say, this is one that's going to need to go into expert hands like one of you guys, or it can be taken in a lab? There are certain PVCs that you would say, stay away from, morphology-wise.
Well, I think the example we saw is a very good example for several reasons. One, the anatomical location. Second, the simple fact that it's a third redo. Did I get that right? It's really the first thing you need to realize if you're doing a third redo is it's highly unlikely that this is going to be a walk in the park, no matter where the previous case was done, whether it was done in your own lab or somewhere else. It's going to be tough. It's just selection that brought this case to you. So in these cases, I think these specialized tools are very helpful. Like you said, Devi, probably useful and wise to do this in high volume centers using specialized tools. I also have a question for Ammar, if I may. Great video, by the way. What is clear is that you need to get a very deep lesion for this very challenging particular focus, right? And you eliminated ultimately the PVC from the LVOT, but one could argue that maybe you'll just need to do all these ablations anyway, and the particular order may not even be important. It might have been, if you had started in the LVOT, that you would have finally suppressed it from the RVOT. And what we sometimes see, but it was a bit hard to make out in the video, is that you see these minor changes in ECG morphology suggesting that you're pushing the exit somehow. And is this something you observed in this case? And do you think it would have supported a deep focus rather than a purely LVOT focus, for example?
Yeah, very, very good question. You're absolutely right. I mean, even within, before we did ablation, there was very subtle morphology changes in the PVC, again, suggestive of a slightly different exit, consistent with a deeper focus. Excuse me. I think you're right. I mean, obviously, I don't know for sure, but if I had ablated from other areas first, I suspect I would have probably had to do ablation from the epicardial region, through the AIV. Again, in part, biased by the prior experience where they had performed RVOT and LVOT ablation and were unable to successfully eliminate it. Now, sometimes, and I've seen this where you ablate in the exact same area as where, you've ablated before, for even my own cases, and we weren't successful the first time just because of a very deep focus, but now we are. And I think in part that's probably because of the muscle thinning that we get with the first ablation that then we can penetrate. But again, that's not always the case.
Well,
Yeah, they can add one.
Yeah, please go ahead.
Oh, just one comment about the benefit of PFA in that location in the AAV with radio frequency. Since you're working with very high impedance, sometimes it's impossible to deliver any meaningful energy there. And that's why we fail so often. And PFA give us a better chance of creating some meaningful lesion in those locations. And it's impressive because this has been seen also in Europe with Joseph Kastner and Peter Peichel using the Centauri Galaxy as a ablation platform. You can be very close to the LAD in the adjacent vein and still don't cause spasm. I don't understand why that happens in the AIV. If you go direct epicardial, you see spasm. If you're in the AIV, it seems like you don't see as much spasm. I think that's something we need to sort out, but it's fascinating.
Agree.
Well, on that note, I'm going to wrap up this session. Thank you, Ammar, for a great case. And Tom and Pasquale, thank you so much for your input. The next session of RIO US Focus is coming right up.